Perfect. I'll just go on. I will present to you a 66-year-old female admitted to our center with chest pain and a couple of episodes of vomiting. There was a history of, followed by a history of 3 weeks of cough, non-productive but viral illness, but no dyspnea. Her physical examination was entirely normal. And this is her 12 ECG and presenting in emergency department with some changes in the anterior lead. Her initial labs shows that she has a positive troponin. So she has a background history of type 2 diabetes mellitus with HbA1c of near 7%. Her troponin, as you can see here, is rising. And she has a pro-BNP of more than 3,000. This is her chest X-ray, which didn't show anything abnormal. Her echocardiogram was mildly dilated with an ejection fraction of 35% and regional wall motion abnormality, mainly in the anterior LAD territory. So we took her to the cath lab, did an angiogram, and the angiogram shows mainly disease in the left anterior descending artery. So we had a MDT discussion, and we thought we will proceed for PCI. So this is her right coronary artery, just mild disease. LAD, the proximal circumflex, there is probably 70% disease. And in the LAD, at the bifurcation of diagonal 1, there is calcific severe disease. So we thought we'll do a provisional approach here. So 2 wires started by ballooning the LAD, and I suppose here it was a NC balloon, and we felt, I suppose that at that time the balloon went up nicely. Then we took a DCB balloon into the, as we planned, into the diagonal with good result. This is my next image. So I took a stent, put it down to the LAD, and the stent was not delivering, okay? And I thought, okay, maybe I need to pre-dilate a little bit more with a scoring balloon. I took the stent out, and I only saw a balloon without a stent. So I looked at my technician saying, where is the stent? So we screened, and this was this is what I saw. So what is next? I suppose, calm down, keep calm, call people, ask for help, ensure patient safety, make sure that, that you actually talk to your team, just acknowledge what you have, what we have done and what we're going to do next, okay? So I suppose this is a coronary stent loss. There is 4 main types of that. A partial stent loss in the coronary artery, total stent loss in the coronary artery with a guide wire in situ, a total stent and guide wire loss in the coronary artery, and obviously coronary stent loss in the aorta or peripheral circulation. Now, obviously, thing here, you have to remember, when you have, I have my stent is in the coronary part of it, and the other part of it just floating really in the aorta, which was not really a good scene. Having said that, obviously, first thing, try not to lose your wire, and this is at the back of my mind, and unfortunately, I lost my wire. Anyways, so just a little bit of preview, partial stent loss in the coronaries. So there are multiple techniques to try to retrieve a stent. So low pressure balloon inflation, where basically you put a second wire, or even if the balloon can go through the previous the wire, and start with slow inflation, start pulling the stent back into your guide, your guide, yeah. And this is what happened. This is where I have unfortunately lost my wire at this stage. A small balloon inflation technique, you put a balloon into the stent and you inflate it a little bit, and hopefully that will get the balloon stuck, and you just pull it back. Retrieval technique, so obviously here depends where the stent is, so it's either by snaring or by just inflating the balloon against the the wire. So you have a snaring technique and then a multi-wire technique. So where you put multiple wires and you just basically with your torquer, you put the wire, you roll the wires, and hopefully that will hold into the stent and you can hopefully easily pull it back. And then crush technique, and obviously this is not something that it would be possible in my case because the stent is actually in the aorta. So at this stage, I'm thinking I've lost my wire. What do I do next? Obviously, and the patient here was having pain in her arms, unfortunately, because of spasms. Lost my wire. Do I speak to a surgeon? Anyways, I think it's important to address all these things at the back of your head. Ask your colleagues to come and help you, out. So finally, there is also advanced deployment stent and advanced in employment. So advanced with slightly inflated balloon, so deploy the stent at the target site to inflate balloon inside the stent. This will allow, obviously, the operator to advance directly and deploy at a target lesion or a non-consequential location. So I'm just going a bit faster because I can see the time is going. So this is what happened. So I went femoral, took a second guide, and you can see now on the left side of the screen or your right side that the stent got stuck, snared. Sorry. 10 seconds more. You can see here the snare is coming up, and now you will see me running like so fast. Look, running. I'm just running. Okay. At this stage, I was so excited. Okay, but the stent stuck in the femoral. Okay, and this is my stent. Now, to be honest, at this stage, I must say, and we have to appreciate that, we can get operator exhaustion. It's a thing. I was exhausted, and I was not keen to actually go left side, try to retrieve it, and so on. I spoke to my surgeon, who actually did it within less than 2 minutes under local anesthetic and sedation. And he took the stent back. As you can see, the stent is elongated and damaged. Anyways, the patient came back to the cath lab. And at this stage here, I acknowledge this is a nodular calcium that got my stent stuck, that pulled it out. So on my next procedure, I used NC balloon, scoring balloon, cutting balloon, IVL, you name it. I've used it to prepare this lesion quite well. And we ended up with a good result. This is the stent on the second occasion. It went nicely. Can I have just less than 1 minute, please?
30 seconds.
30 seconds. Thank you. Okay, so you can see here the stent nicely going in and out through the lesion. And this is my final result, which acceptable. ECGs are fine after patient presented up. So patient is well. She discharged home. Actually, with medical therapy, she improved. Her heart function is also improved. I think it's important that we look at what we've done and we reflect on what we do. So my home take message, coronary calcification remains one of the major challenges for coronary intervention. Coronary angiogram has its own built-in limitation for quantification and qualification for assessment for coronary calcification. Intravascular imaging with IVAS OCT greatly help in procedural planning and selection of device therapy. And we're almost 2025. We have on our shelf armamentarium to fight calcium. So just keep that in mind. And thank you very much.